Hello again, everybody. Now we're going to talk about the nursery examination here. This is a more extensive physical examination. Should be done in all babies within the first 24 hours of life. This is not done in the delivery room. This is something that's done once the baby's been stabilized, all the immediate needs have been attended to, and this is typically done. It can be done in the nursery or it can be done in the mother's room. It doesn't really matter, but this is a more deliberate and comprehensive examination of the baby, looking for any anomalies that may need to be attended to while the baby is still in the hospital with mom. So we'll talk about the purpose of the nursery examination. I'll give you some tips as well as the normal vital signs. That's very important because normal vital signs, you need to know this for the USMLE. Normal vital signs for babies and children are not the same as for adults. Coming from my background in internal medicine, it's easy to think of children as just little adults, but they're certainly not, especially babies. So their vital signs are different, and you need to be aware of what the range is. Physical. We're going to talk here just about the skin, neck, chest and lungs, heart and abdomen. I divided this into two parts just to make it a little bit, make these a little bit shorter. So the purpose of the nursery examination is to identify any abnormalities or anomalies that can impact the infant's current or future well-being. As we're going to talk about when we talk about the heel prick test, the screening test, there certainly are abnormalities or anomalies that may not be present right away that you'll be able to see, and that's why we do blood screening tests. But when you're doing the nursery examination, what you're doing is you're looking for things that are there, that are present, and then you can address those. And this should be performed in the nursery or the mother's room, wherever the baby's at, in the NICU, within 24 hours of birth. So the exam that you're doing in the delivery room, when you're taking your APGAR score, that's not a comprehensive physical exam. What you're really just doing there is ensuring the stability of the baby. Here, we've got a stable baby now, and we're doing a comprehensive physical examination once things have been relatively stabilized. About 20% of all babies are going to have one or more anomalies, and the presence of a couple or even a few isolated anomalies is not unusual, and having an anomaly does not indicate all the time that there's an illness or a pathology going on. So don't make the mistake of thinking that if the baby has one or two of these features, that there's something pathologic. Some of these things are just normal variants. However, if you put together 3 or 4 or 5 normal variants, it makes a sequence, and that may be indicative of an underlying pathology. So some of these sequences or constellations of anomalies are associated with various congenital illnesses. So some tips for doing the newborn examination, or I should say the nursery examination, I suppose also for the newborn examination though. One, you want to remember that babies don't have really good temperature regulation yet, and so you want to make sure that your hands are nice and warm since you're going to be touching the baby. So a good way to do this after you've washed your hands is to rub the palms of your hands together very quickly, create some friction, and that will warm the surface of your hands. It's kind of a nice thing to do really for any patient because nobody likes cold hands. Also, you want to disinfect not only your hands but the surface of your stethoscope with an alcohol wipe and allow it to dry. Big reason there is because you don't necessarily know if the baby has any congenital immune deficiencies, so you want to try to be as clean as possible. And then remember, the baby really does not like to have its face, eyes, or ears touched at all. So try to wait and do that till the end so that you don't have a crying baby while you're trying to listen to the heart or lungs. You'll want to start your examination just with a general observation, looking for any gross anomalies without touching. So some of the things you can do here, look for skin color, listen for the breathing quality, if there's any really loud, adventitious lung sounds, you may be able to hear that. Look at the chest cavity, look for symmetric inflation. And then also, when you're doing the vitals, don't be confused. The normal range for an infant is different from that of an adult. So the normal heart rate is between 120 and 160. Respirations is between 30 and 60 respirations per minute. The blood pressure is typically between 50 and 70 millimeters of mercury systolic, and the temperature, just like an adult, is between 97 and 100.3 degrees Fahrenheit. Okay, so the skin. First off, you're looking at color. So the skin is normally pink, although, like I said, there can be temperature dysregulation. The baby may have the baby may have blue extremities with a pink body. That's not entirely unusual, but the skin, by the time you do the newborn examination, in general, should be pink. So some of the abnormalities here would be jaundice. So in the first 24 hours, if the baby has jaundice, that's never normal. So congenital jaundice, physiologic jaundice, is common, and that's fine. That's all well and good. But if it's in the first 24 hours and the baby has jaundice, that needs to be addressed. So this is associated with hemolytic processes, with Rh isoimmunization, and congenital hepatitis. So if there's any jaundice in the first 24 hours, you need to get a CBC, look at your total bilirubin and your breakdown of bilirubin to conjugated and unconjugated, and then go from there. If there's pallor, that, of course, just like in anybody, would suggest an acute or chronic blood loss. It can also suggest acidosis. Cyanosis is suggestive of poor cardiac output and warrants immediate investigation. Although sometimes if the baby is cool, it can cause those blue extremities. Typically babies are put in a nice warm area, so they should look normal. Plethora, redness, is associated with polycythemia, just like in anybody else. Birthmarks. So this is a big one. A lot of these are normal, but depending on the pattern, how they show up, it can be indicative of an underlying process. So a capillary hemangioma may not show up in a baby within the first 24 hours. Sometimes this doesn't show up until much later. But the capillary hemangioma is a spot. Usually it's papular. It's like a mole, and it's red, and it typically occurs on the head or the face, and they grow like a mole, but then they spontaneously involute around 1 to 2 years of age. And a lot of times parents are really, really concerned about this because the baby's got a big red thing on their face. But these are typically completely normal, and they will go away spontaneously. You don't need to do any surgery. A port wine stain is a flat red birthmark. So it's just like any other birthmark that you could have, but it's red. And it's flat, so it doesn't have any texture to it like a hemangioma. Now, if you have a port wine stain on the face and it's unilateral, you need to be concerned about Sturge-Weber syndrome. Mongolian spots are typically seen in darker skinned individuals, blacks, Hispanics, and these are blackish blue spots, and they're a lot of times seen on the lower back and buttocks. And all these are melanocytes gone a little bit nuts. So these are clearly marcated, unlike bruises, where bruises tend to be more poorly defined. So that's really the major differential, is bruise. But a lot of times you'll see these Mongolian spots in the first day or two, and that's typically not a bruise. But that's really the major differential. Café lait spots are pretty famously known. These are those light brown spots. They look like your typical birthmark. These can be normal if in a white infant if there's 3 or less, and in a darker skinned infant it's been defined as a black infant if there's 5 or less. But if there's 6 or more, that's associated with neurofibromatosis type 1. And café lait spots are also associated with other congenital illnesses, including tuberous sclerosis. So this is a capillary hemangioma, and this looks like a newborn, so this may get a little bit bigger before it gets smaller. Here's a port wine stain, so this is flat, and these can be treated cosmetically. If they're on the face, a lot of times the parents are going to want these to be treated In my opinion, I would too. So these can be treated cosmetically. This is a port wine stain as it would appear in Sturge-Weber syndrome. So note how this port wine stain terminates at the midline. This is how it appears in Sturge-Weber syndrome. Whereas with this port wine stain, it crosses the midline. This would not be Sturge-Weber syndrome. These are Mongolian spots. So you can see the clear demarcation between normal skin and the darker pigmented skin. This is a Café spot. So you'll want to count the total number of Café spots. Once you see one, look a lot closer at the baby for more. Because the more Café spots there are, especially if there's more than 3 in a white infant or more than 5 in a black infant, it is associated with congenital problems. You want to look at the texture of the skin. Is there cracking or peeling? That's typically seen in post-term infants. Is there any edema, generalized or local? Is there bruising or petechiae? That can suggest birth trauma or possibly a bleeding disorder, just like in anybody else. Cutis marmorata is modeling of the skin. That's a normal variant. Like mentioned previously, babies have poor temperature regulation early on, and this is something that happens in temperature dysregulation. It happens in adults too, a lot of times in your hands if you go from a cold room to a warm room. These are just capillaries that you can see through the skin, and this is temporary. This should go away. Vernix caseosa is that notorious curdy, greasy material that's on the baby's skin at delivery. That's totally normal. If you've done deliveries, you've seen babies, most term babies have a little bit of this stuff on them at least. Erythema toxicum is a pink maculopapular rash that is seen after the first 24 hours. So if you see any rash that looks like erythema toxicum in the first 24 hours, it's not erythema toxicum. This is an autoimmune process. It's pretty much just the immune system asserting itself, and it's totally normal. It goes away after a few weeks. I'll show you a picture of this in a little bit. This needs to be differentiated from Staphylococcal scalded skin syndrome, and this is a diffuse red rash, but it looks like a second-degree burn. It looks like you had a blister and it ruptured, and so you've got denuded skin. And if you do the Nikolsky's test, where you rub a metal instrument or something, place pressure on the skin, that will cause denudement, and that's a positive Nikolsky sign, and that's consistent with Staphylococcal scalded skin syndrome. These babies are going to need broad-spectrum antibiotics and fluids. So this is Vernix caseosa here, and Vernix caseosa is Latin for cheesy varnish. So that's kind of what it looks like. It looks kind of like cheese, like you put some mozzarella cheese on this baby. This is the Cutis marmorata. You may have seen this on yourself at some point in your life, and this is just capillaries being a little overreactive to temperature dysregulation. Totally normal in the baby. This is Erythema toxicum. This is a migratory rash. It's maculopapular. But this is Staphylococcal scalded skin syndrome. Obviously, this is totally different. You see that there's denudement of the skin and layers of dead tissue here. Subcutaneous fat necrosis is another thing that can be seen, especially if there is significant trauma during the delivery. This is likely what it's from trauma, but technically it is still idiopathic. These are erythematous, indurated, hard nodules. They may be accompanied with hypercalcemia a couple weeks later. It does not require treatment. The subcutaneous fat necrosis itself, the skin lesions don't require treatment. However, because of the hypercalcemia, you should check the calcium levels periodically. So this is subcutaneous fat necrosis here. If you were to feel these, these would be very firm. So you look at the neck too. What we're really looking for in the neck is webbing and masses. So webbing is excessive nuchal skin, and that's associated primarily with Turner syndrome, so little girls that have only one X chromosome rather than two. Neck masses are important to find right away because these can get infected. So the thyroglossal duct cyst would be a neck mass on the midline, and these will move with swallowing and tongue protrusion. So if you put the baby, if you're not sure if it's midline or not, when the baby is nursing or drinking from its bottle, look for that mass to move. And if the mass looks like it's on the midline and it moves, that's a thyroglossal duct cyst. And if you look at the word thyroglossal, it's thyroid tongue. Glossal is tongue, so it moves with the tongue. Anterior to the sternocleidomastoid, the anterior part of the sternocleidomastoid. So this is going to be lateral to the midline, but it's on the anterior part of the sternocleidomastoid muscle. A mass there would be a branchial cleft cyst. These can also become infected. And then posterior to the sternocleidomastoid muscle, or on the posterior edge of it, is if there's a mass there, that's likely a lymphatic problem known as a cystic hygroma. You can also note congenital torticollis, and usually this is just a problem with the sternocleidomastoid muscle itself. With congenital torticollis, typically all that's needed is some physical therapy. So here's webbing. You can see here excess skin on the neck. This is a thyroglossal duct cyst. Obviously this is not a newborn, but if you were to ask this kid to swallow, this would move. This is a branchial cleft cyst, so note that it's not on the midline, but it's just lateral to the midline. It's still on the anterior part of the sternocleidomastoid muscle. And this is torticollis here, so note that the baby's head is turned here. And if you were to manipulate the baby's head over the other to the other direction, you probably feel a little bit of resistance, and you let go and the baby's head will turn back to this direction. And this would be a problem of the left sternocleidomastoid muscle. It's pulling the head to the left. This is a cystic hygroma here. They're not always this big, but note that this is posterior. Okay, so the chest and the lungs, you want to assess the chest for any breaks. Particularly you're looking at the clavicle there because that's a very commonly injured bone during more traumatic or surgical deliveries. You want to look at the chest for air entry, make sure it's bilateral. If it's not bilateral or it doesn't look right, get a chest x-ray for a possible pneumothorax. Breast hypertrophy is usually normal, and that's typically a response to circulating maternal hormones. There may even be some milk produced. I can't say it's common, but it's not unusual or not even necessarily pathologic, but it should be noted if it's there. Supernumerary nipples are unusual, but that it typically doesn't mean anything significant, and they can be removed later on. They usually just look like little moles. They don't look like fully developed nipples all the time. So this is Pectus carinatum here. I think I will talk about this in a little bit. Pectus carinatum is just a bulge of the sternum, and Pectus excavatum is an indentation of the sternum. So maybe I didn't put this anywhere. Anyway, now you know. Pectus excavatum, you should be aware that this is associated, well, it can be associated if it's severe enough. It can cause compression of the mediastinum. You also want to auscultate for breath sounds. So if there's absent breath sounds on the left, that can indicate a pneumothorax, particularly if it's hollow sounding when you percuss. Or it can indicate a congenital diaphragmatic hernia. Either way, you're going to get a chest x-ray. If you get just blackness on the left side, then it's probably a pneumothorax. If you see bowel, or if you hear bowel sounds on the left side of the chest, then it's likely a congenital diaphragmatic hernia, and you'll want to consult pediatric surgery. If there's an elevated respiratory rate or adventitious breath sounds, that can indicate respiratory distress. In this case, you'll also want to get a chest x-ray. And if there's decreased breath sounds, particularly in premature babies, typically this indicates hyaline membrane disease, where you don't have sufficient surfactant. In this case, you'll want to get a chest x-ray to confirm your diagnosis. So this would be a congenital diaphragmatic hernia. The pressure in the peritoneum is higher than the pressure in the chest cavity, and so this is if there's a defect the diaphragm. It's going to push the bowel contents into the chest cavity. Another thing that you'll note with congenital diaphragmatic hernias is that the point of maximal impulse of the heart is going to be displaced to the right because it's pushing the mediastinum over. So in addition, you'll want to listen at the heart. The heart rate should be anywhere between 120 to 160 beats per minute. Murmurs are normal in the first few hours after birth. It takes a little while for the normal adult circulation to come, so it doesn't happen right away. But if it's been certainly after a day after birth, then you'll want to consider congenital heart disease, and you'll want to get echocardiography. Especially, of course, if there's cyanosis. Any muffled heart sounds suggests a pneumomediastinum. That can happen as well. You'll want to listen to for the point of maximal impulse. That should be towards the left side of the midline. If it's displaced to the right, that suggests CDH, as I mentioned. If it's abnormally to the left, then that suggests cardiac enlargement. You'll also want to manually check pulses on all four extremities. So the abdomen, you'll assess its shape. You want to, and this goes for adults too, when you do the examination of the abdomen, you want to do everything but touch and manipulate the abdomen, because if you press on the abdomen or you manipulate the belly, that's going to increase your the bowel sounds. The bowel sounds they'll be more frequent and louder, and so it'll give you false positives. So you want to look at the abdomen, auscultate it, and then do the palpations last. So when you're assessing it, scaphoid abdomen would suggest a congenital diaphragmatic hernia because you've got bowel that's moved up into the chest cavity. An enlarged abdomen can indicate gas. It can also indicate a mass or peritoneal fluid. You really have to look at the clinical context there. Also, you'll want to ensure the umbilical stump is not bleeding or infected. This is a perfect time to do that. You'll want to auscultate for bowel sounds. You'll look for any herniations. An umbilical hernia is pretty common, and that will be right at the umbilicus. An omphalocele is a midline defect. This is where you have bowel contents spilling out of the body, but they're covered with that protective membrane. This is associated with Beckwith-Wiedemann syndrome as well as other problems. And then gastroschisis is much more emergent. In this case, you have just bowel contents just spilling out, small intestine spilling out without that protective membrane. And this is a defect just lateral to the midline. It's typically diagnosed in utero, but I guess in the case that it wasn't, then you would diagnose it. Probably you would diagnose it right away when the baby's born. But it's included here just to contrast with the omphalocele, because these two, omphalocele and gastroschisis, oftentimes get confused. Just remember that the omphalocele is covered with a membrane, and the gastroschisis is literally just bowel contents just spilled out. And in children with gastroschisis, there is an increased risk of malrotation and ischemia. You'll want to palpate the liver and the abdomen for masses. The number one true abdominal mass is a polycystic kidney, but there are lots of abdominal masses. So this is an umbilical hernia. These tend to go away on their own. And you also probably can note the Cutis marmorata here too. This is the omphalocele. Note the protective sac. This still needs, obviously, surgical consultation. And then gastroschisis. Here there's no protective sac. You see small bowel and what's probably large bowel here.